which ends up inflaming the little duct and occluding it, or basically blocking it. Now, gallbladder disease as well, we talked about a gallstone or even inflammation that now blocks this duct. And even cystic fibrosis, where we have serious mucus with cystic fibrosis. This mucus can block the pancreatic duct. Now, a really odd one here is surgeries, or a diagnostic procedure that can accidentally cause trauma and inflammation in this area. Now, this is very common with an ERCP procedure, an endoscopic retrograde cholangiopancreatography. Big long word. So please write that down. ERCP. This one is highly tested. Typically used to clear gallstones or diagnose problems in the bile duct, a scope is passed through the mouth, down through the small intestine, and through the bile and pancreatic duct too. Now, if this scope accidentally scratches the duct here, it can cause major inflammation, which blocks the pancreatic enzymes from getting out, leading to pancreatitis. Now, in terms of the signs and symptoms, pain is a huge NCLEX tip, so write this down. Epigastric pain, like heartburn, in the left upper quadrant. So, left upper quadrant pain that radiates to the back. Huge key terms right there. Write those down. The majority of the pancreas is in the upper left quadrant here. So, don't let the NCLEX trick you. It's not the right upper quadrant pain that radiates to the shoulder. This is typical of gallbladder inflammation on the other side, called cholecystitis. And it's not right lower quadrant pain with rebound tenderness. That's typical of appendicitis. So a top missed NCLEX question states which client should the nurse see first? And it's a client with epigastric pain after an ERCP. Yes, just think of the double E's here. Epigastric pain from an ERCP can erupt the pancreas, causing pancreatitis. And bruising is another critical sign. So we have Turner's sign and Coulin sign. Turner's sign is bruising or ecchymosis on the flanks or the sides of the body, and Coulin's sign is edema and bruising around the belly button, also called the umbilicus area. So just think T for Turner's sign, you can see the bruising when you turn the client. And C for Coulin's sign, just think of a belly ring shaped like a C for colon. There's bruising around the belly button area. Now, clients can also present with liver disease symptoms too, as the liver area can get backed up from this inflammation in the bile duct, causing jaundice, that yellowing of the skin, from the elevated bilirubin. And we can also see hypotension, that low BP. This is typically from internal bleeding and even ascites, that fluid in the abdomen that makes the stomach region big and bloated with fluid. So Saunders mentions a client admitted to the hospital, which assessment finding would be consistent of acute pancreatitis. Select all that apply. So gray-blue color at the flank, abdominal guarding and tenderness, and a big one here, left upper quadrant pain that radiates to the back. So again, write these three down and know them. In terms of labs, we have elevated enzymes, specifically amylase and lipase. Now, lipase is the biggest one here. Write that one down. It's always the most indicative of pancreatitis, so it's the most tested. We also see elevated glucose, indicating hyperglycemia. This is from the lack of insulin, as it can't get out of the pancreas too. So just think insulin puts sugar into the cell. So without insulin, well then no sugar can go into the cell. So it ends up just sitting around in the bloodstream, and therefore causing hyperglycemia, that elevated blood serum glucose. So clients may have to go on insulin momentarily. Next, we have elevated WBCs over 10,000, and we can even see a fever from all the inflammation. And since the liver may be having trouble, it can't produce coagulation factors like normal, so we see elevated coagulation time with elevated PT and APTT. Huge risk for bleeding here. And elevated bilirubin, which will cause jaundice, as mentioned before. Now, in terms of complications, typically the most deadly are the most tested. So, number one, write it down, is ARDS, acute respiratory distress syndrome. Many students get this wrong. This typically results from massive inflammation all over the body that can lead to leaky blood vessels, filling up the alveoli inside the lungs with fluid, which we cover more in detail in the respiratory course. The second thing is peritonitis, the inflammation of the peritoneal cavity inside the abdomen, typically caused by bleeding from that inflamed pancreas. So we always assess for and report to the HCP. Write down these top three here. A fever over 100.3, rebound tenderness, as well as a rigid or board-like abdomen. Those three are the most commonly tested out of 10,000 questions, as well as increased pain and tenderness, restlessness, and a fast heart rate and respiratory rate, known as tachycardia and tachypnea. This typically means internal bleeding, and it could mean deadly peritonitis and the patient goes septic and die. So this is a big medical emergency here. So make sure to pause the screen and write those down. Now, in terms of interventions, we always put the patient on NPO. No eating, no drinking, nothing per oral for at least 24 hours, since eating and drinking stimulates more enzymes, which leads to more pain and more inflammation. Number 2 is we insert a nasogastric tube for suctioning, so an NG tube. This decreases the gastric, or basically the stomach, to cause gastric decompression. Number 3 is we use IV pain meds like hydromorphone, brand name Dilaudid. No morphine. A lot of students don't know this. Morphine can cause spasms inside the pancreas that can lead to more pain. Next, we use IV fluids, and we also monitor glucose, specifically for hyperglycemia. Remember, the pancreas is having trouble here, so it can't release insulin. So we end up with hyperglycemia, and the patient may have to go on insulin momentarily. Now for pharmacology, we use the acid reducers here. So antacids, proton pump inhibitors, those end in prazole like pantoprazole, and H2 blockers like famotidine, which we cover in full detail in our pharmacology course. Now a common exam question here is, after performing a physical assessment and obtaining vital signs for a client with acute pancreatitis, which nursing intervention is priority? IV fluids and pain control. And Saunders had a question. A physician orders were written for a client admitted to the hospital with acute pancreatitis. Which order requires follow-up by the nurse? Full liquid diet. Yes, remember, clients should be NPO for at least 24 hours. So we must call the doctor and question the order. Now, eventually, clients will progress to a bland, low-fat, low-sugar diet, in order to give the pancreas enough time to make lipase and insulin to break down the fat and let sugar into the cell. So write it down, a diet low fat and low in sugars. And we also add enzymes with meals. Now Hesse mentions, which foods would be most appropriate for a patient who recently had a bout of acute pancreatitis? Select all that apply. So remember, before looking at the options, just think low fat and low sugar. So fried chicken, do you think that's okay? No, there's way too much greasy fat. How about potato chips? Nope, too much fat. How about grilled chicken and a baked potato? Yes, the key term there is grilled chicken. How about reduced fat cheese and whole wheat crackers? Yes, the reduced fat is the key term there. And whole milk with cookies. No Santa Claus here. Whole milk has a lot of fat, and sugar inside the cookies are not good. All right, that wraps it up. Now for the practice questions on pancreatitis. Question number 1. The nurse is caring for a client with acute pancreatitis. When asked by the client what will be happening during the client's scheduled ERCP, endoscopic retrograde cholangiopancreatography, the nurse responds that, go ahead and pause your screen and try your best to answer this question in about 60 seconds or less. Okay, let's break this question down, following the question breakdown strategy. So first, look at the key terms in the question: acute pancreatitis, ERCP, And the question's asking what will be happening during the procedure. So again, think of a few things you know about those key terms. So an ERCP is when a tube goes through the mouth into the pancreas via the bile duct to assess the organs. So let this big long name help you. Endoscopic means a scope, basically a tube with a camera. Retrograde means moving past. Choleangio is that bile duct. And pancreo refers to the pancreas. Ography is that video, or basically X-ray videography. So option A, the provider will laparoscopically remove the client's pancreas while the client is under general anesthesia. No, there's no cutting here or slicing the patient open, basically surgery. Laparoscopically means surgery. Now option B, the provider will be using a combination of X-ray and guided endoscopy to assess the pancreas, gallbladder, and bile ducts. Yes, this is a guided scope into the pancreas, gallbladder, and bile ducts. Now, option C is incorrect. The provider will be using radiology to guide the removal of gallstones and the gallbladder. No, once again, no removal of gallbladder, we're only assessing here. And option D is also incorrect. The provider will be making a midline incision to remove any diseased part of the small intestine. No incision here and no surgical cuts here. Now moving on to question 2. Which is the most critical assessment finding in a client diagnosed with acute pancreatitis? So once again, pause the screen and try your best to answer this question. Now, following our question breakdown strategy, once again, first look at the key terms in the question here. So the most critical assessment finding, so just think what kills the patient the fastest, and always think the worst case scenario for pancreatitis. Now looking at our options. Option A, a bluish discoloration around the client's navel. Yes, this is a classic manifestation for Coulin's sign, basically bruising around the belly button, which can indicate bleeding under the skin from hemorrhagic pancreatitis. Now, option B is incorrect. Reports of mid-epigastric pain. No, this is incorrect because it's common and to be expected with pancreatitis. And option C is also incorrect. A blood glucose of 212. Now, this is technically elevated since normal glucose is 70 to 110, but this will not kill the client, so it's not the most critical assessment finding. Now, option D, also incorrect. Reports of nausea and vomiting. Once again, it's not going to kill the client here, so option A is the most critical as it indicates bleeding, that hemorrhagic pancreatitis. All right, that wraps it up. Thank you